So, welcoming everybody here today. Um, Welcome to our next in the series on National Lung Cancer Screening Program. And we're looking at additional findings detected during lung cancer screening today. And just reminding you that everything is current at the date of today, 12th of August. So if we have the next slide, Olivia, please. And I'd like to acknowledge the traditional owners of the lands on which our work is taking place, the Wurundjeri Wurrung people, the Boonwurrung people and the Wathaurong people. And we pay respects to elders past, present and emerging, as well as paying respects to any Aboriginal and Torres Strait Islander people who are joining us today. Thank you. So just some housekeeping before we get going. So everybody is meant to be muted, so please keep your microphone on mute if anything changes. You have a chat box there. Please ask any questions via the chat box. And the session is being recorded, so other people or you can look at it again via the PHN website and the YouTube channel. And please, if you want to get your CPD points, please put your correct name in the chat so we know who you are. If you're iPhone 50, we won't know who you are. So please make sure it's your name that you would have registered with so we can give you your CPD points, please. Next slide. Now, if you don't know how to change your name, click on the participants list that's at the bottom of your screen and click on your name and rename yourself. So you'll need to rename yourself and then click done or change or rename depending on what things are. So there's usually 3 little dots to the side where you can rename yourself. So please look at that and rename yourself if you need to. So the schedule that we have for today, we have a poll in a minute we'll be having with Asha. Bonnie is going to do the poll. Then we're going to be looking at some case studies on additional findings, and then more specifically looking at coronary artery calcification, emphysema, interstitial lung abnormalities, and I'll be looking at how as GPs we communicate with our patients about these additional findings. Then we'll be doing a presentation poll, post-presentation poll, and looking at how you can refer into rural Melbourne and how you can access more information on the health pathways. Thank you. And there'll be questions and answers at the end. So if you do have questions and answers, put them in the chat as we go, and we can answer them at the end or just save them to the end. So we have some amazing speakers from Royal Melbourne. We have Asha Bonney, a respiratory and sleep physician at the Royal Melbourne, and she's also already been doing some of these presentations. She's also done a lot of work in the area of leading lung cancer screening and is a clinical lead of the Lung Nodule Clinic at Royal Melbourne and lead of the Lung Nodule and Screening Program at Royal Melbourne Hospital. So she's got a lot of expertise in this area. We have Associate Professor Renee Manser, also a sleep and respiratory physician at Royal Melbourne, and Peter Mack. And she is eminently qualified to be here today and has extensive experience in lung cancer diagnosis and management, and has been in principal investigator in an international lung screen trial. And Alistair Miller is also joining us, another respiratory and sleep physician at Royal Melbourne, and Peter Mack, who's presented here before, and Dr. Kay Leong is in multimodality cardiac imaging specialist and has come to help us with the coronary calcification, and has a lot of expertise in this area, doing advanced imaging training in cardiac MRI and CT, and has an advanced cardiac imaging expertise. So thank you. So let's start with the poll, please.
Great, thanks, Sue, and welcome everyone. So we might launch the poll, Olivia, if that's all right. Great. So you should have had the poll questions just pop up on your screen. So we'll give it a few minutes to answer those if you could. So the first question is, have you actually enrolled a patient yet in the National Lung Cancer Screening Program? Yes or no? The second question is with regards to a radiology report. So would you routinely read the body of the radiology report, looking at additional details for scan abnormalities? Before we do this talk, we're interested to know how commonly you might refer incidental or additional findings to specialist clinics. Is it something you do commonly, or do you agree or disagree? How confident are you in assessing incidental emphysema? And you can rate that again between strongly agree and strongly disagree. How confident are you in assessing incidental coronary artery calcification? And again, strongly agree to strongly disagree. And have you actually had the chance to read the National Lung Cancer Screening Program guidelines as well? Yes or no? So we'll just give it another couple of minutes for people to just finish off their responses.
And yeah, you might need to realise that you have to scroll down if you can't see past the two top questions. So you scroll down.
All right, we might end it there, Olivia. Wonderful, thank you. And I might share my screen. All right, you can see my slides, hopefully. Excellent. So with this first talk, what I wanted to cover really was a bit of an overview, looking at some of the broader definitions for additional findings, to touch on the frequency of additional findings, the reporting, the additional findings guideline, and then we'll end on just some brief cases to lead into the other talks. So additional findings are also known as incidental findings. It's the same thing. It basically refers to findings that were not the purpose of the test. So for lung cancer screening, that's anything that is not a lung cancer related finding or a pulmonary nodule, would be classified as an additional finding. And what you can see here from this imaging slice is with low dose CTs, there are a lot of additional findings that we can detect. It's very different to other screening programs with mammograms or fecal occult blood tests. We really can find things like coronary artery calcification, vertebral crush fractures. And so the key thing is actually differentiating between findings that are potentially clinically significant or otherwise labelled as actionable, or those that are non-actionable or not clinically significant. What we do know is that additional findings are very common, and America has been screening for over 10 years now, and one of their earlier studies found that 94% of participants had at least one additional finding. For us, as part of the International Lung Screen Trial in Australia and Canada, we found that 73% of our participants had at least one additional finding. I think the key thing to highlight, though, is when we restricted that to those that are actionable, that are potentially clinically significant, that was around about 17% of additional findings. So most are not clinically significant. The other thing I wanted to highlight was when we look at the National Lung Screening Trial, which is the largest randomized control trial from the US, they reported their rates of extrathoracic cancers. And what you can see here is less than 0.5% of participants had an extrathoracic cancer detected on low-dose CT. So most of these additional findings are not malignancy or not cancer-related. So what are they? So, I mean, we've published a full list of the additional findings that we found in Australia and Canada. And this is just a screenshot to show you the two most common ones. The most common in our cohort of over 2,000 Australian participants was actually coronary artery calcification. So you can see here, just over 67% of our participants had some degree of coronary artery calcification. The next most
consequences, right? You keep no.
The next most common finding was actually emphysema. So again, over half of our participants had emphysema, and that's not surprising when we think about the eligibility criteria for lung cancer screening. People who are of an older age group, who have a significant active tobacco smoking history. There are a lot of shared risk factors. Of note, particularly with our emphysema, most patients only had trivial or mild emphysema. So very few patients actually had severe emphysema. The other thing to note was actually the differences that you can get in reporting based on who's reporting. So again, this is from America, and they looked at the reporting patterns of additional findings based on whether it was reported at an academic or a university centre versus a community radiology centre. And what they found was that the academic centres tended to report much more frequently additional findings, and that was particularly true for things like coronary artery calcification and incidental lung abnormalities. And that's why we're really fortunate that in Australia, as part of the National Lung Cancer Screening Program, we are having structured reporting. And there are quite clear guidelines for reporting radiologists about the types of additional findings that they're going to be looking for and commenting on as part of the report. So you may or may not have seen some reports if you've already referred patients back to the screening program, but essentially there is a fairly standardized template. Every radiology company is a little bit different, but they do specify actionable additional findings as part of the report. You can see here with this radiology company, they've got the broad overarching system. So for here they've said lungs, nothing applicable, but they've also then specified what they've looked at. So they've looked at emphysema, interstitial lung abnormalities, bronchiectasis, cystic lung disease, diffuse nodular disease. They've looked at the pleura for effusions, thickening of masses, and calcified plaques. They're looking for mediastinal lymphadenopathy, cardiovascular coronary artery calcification, but also valvular heart disease, pericardial effusions, aortic dilatation or pulmonary artery dilatation. There's a number of things in the abdomen that they're looking for with liver and kidney changes, adrenal lesions, aneurysms or pancreas, thyroid. So for this patient, you can see here they've said not applicable for the broad schemes, but for the thyroid, they've said yes. There is a incidental or additional calcified nodule that they've detected on the right. Again, other things are breast lesions, axillary lymphadenopathy, the bones, and then there is an option for other that they can comment on. So in addition to filling that all out in the body of the report, they're also going to provide you with the category for the screening result. So what is the overall follow-up plan? So for this patient, normal scan, repeat CT in 24 months. And then they've put in a comment about the actionable additional findings summary. So for this patient, again, they've highlighted that there's a thyroid abnormality, and they've actually provided a recommendation for further follow-up that you could consider with an ultrasound. This is from a different company where you can see they've streamlined it a little bit more. But again, you've got a patient who's had mild coronary artery calcification. And again, in their conclusion, they did put the screening results, but they've also made a comment again about the presence of mild coronary artery calcification and a recommendation for clinical review. And that should say consider lifestyle modification as well. So that is all part of the new structured reporting, which is what the radiologists have gone through with their training about how to do the standardized reporting for the lung cancer screening program. So this should be present on all of your reports, the presence of any actionable additional findings. The recommendations come from the National Lung Cancer Screening Program Additional Findings Guideline, and I would strongly recommend you have a look at it if you've got the time and if you're seeing patients as part of screening. It's a really great resource put together by the College of Radiologists, and I've just done one screenshot here of how they've actually presented it. So you can see they have, for instance, with liver lesions, they've been very specific to their radiology colleagues about what to report and what not to report. So for instance, for small benign looking nodules, they've actually explicitly said, do not report that in the body of the report, or do not comment on it, versus, and similarly for simple cysts versus larger lesions, where they then again provided a specific recommendation for how you might follow that up. So for hepatic steatosis, for instance, they're recommending following the guidelines and considering a referral to a gastroenterologist. They've also got a separate column where they're actually providing you with the resourcing. So you were interested, you can actually go and have a look and see where are these recommendations coming from as an additional resource. And it's very similar to what the Americans have done with their incidental findings reference sheet, as well as with Europe as well, have a similar document for how to manage additional findings. But I just wanted to end by highlighting that additional findings are common, but most, as I said, are not actually clinically significant. And that's why we're very fortunate that we have this structured reporting that radiologists are going to be following, and why it's important that where appropriate, we're following the guidelines to minimise unnecessary investigations or over-investigation of additional findings that are not clinically significant. It's also important that we speak to patients about the potential or the high likelihood of an additional finding, but also that they're aware of that actually some additional findings won't be mentioned. So if they've had a thyroid nodule that they've known about, it's very possible that that won't be in the report, and that's intentional. But as we're going to hear, there is a significant opportunity to significantly improve health outcomes if we recognise and address additional findings appropriately. So thank you, and I'll hand over to the next speaker.
Good evening, everyone. My name is Kyle Leong. I'm an imaging cardiologist, and tonight I'll be speaking to all of you about the practicalities of assessing coronary calcium and just some of the pitfalls to consider. Next slide, please. So as everyone will be aware, the screening eligibility criteria really captures a large cohort of patients who will have a high pretest probability for having coronary disease. And as you've heard from Asha's presentation earlier, this is borne out in the American data, where coronary artery calcification is one of the most common incidental findings. And certainly, this relationship is dose dependent, with the screening program really only capturing patients with a high smoking history. It's almost a certainty that you will expect to find coronary disease, and the mortality associated with smoking increases in a dose dependent fashion. Next slide, please. If we just consider the American experience, in 2015, so this is pretty old data now, there were about 7 million non-contrast chest CTs that were performed. And if the American lung cancer screening guidelines were applied fully, that would add probably another 7 to 10 million scans. And this would represent approximately 5% of the US population. And with these non-contrast chest CTs, coronary calcium can be assessed, it can be graded, and it can provide very useful information to guide management of cardiac disease. And if we were to extrapolate this 5% figure in the Australian context of 27 million people, then there's a huge potential cohort that will be diagnosed with coronary artery calcification following a non-contrast chest CT. So, the expected increase in workload and in managing coronary disease is not insubstantial. And as such, I think it's important to have a few clear guidelines as to how to approach this problem. Next slide, please. So before I start talking about the non-contrast, chest CT for lung cancer screening, I just want to quickly give some context about a test that will probably be more familiar to most of our colleagues in the general practice setting, and that is the calcium score. Now, as to how we do it, so this is obviously a limited ECG-gated chest CT, very low radiation dose. roughly 0.5 millisieverts. In contrast, a standard chest x-ray is just 0.1. So this will be the equivalent of 5 chest x-rays. It's a very quick test. No preparation is required. And the main thing to point out is that, this is non-Medicare rebated. So patients, depending on where they go, will pay $200 to $300 depending on the provider. In terms of how we actually derive a score, with this being a non-con study, the scan after it's acquired gets uploaded into a post-processing software, and the software will mark areas of high attenuation as possible calcium. And if an area is large enough to comprise at least 3 pixels, it gets marked as potential coronary calcium. We then derive a score, which is really a product of the area of high attenuation and how dense it is. Next slide, please. Now, the radiologist or the imaging cardiologist will look at the images and decide what is calcium or not. Occasionally, there are areas of calcium which are in the valve or in the myocardium or in the aorta that get incorrectly included by the software. So it's the reader's role to just only include coronary calcium. And then we can derive a numerical score. And in this slide here, you can see there are a few different risk thresholds that are important. So, based on the score, we can categorize patients into, these risk thresholds ranging from 0, 1 to 99.
Swearing's not okay, mate. Swearing's really bad.
399, 400 and more than 1,000. And these are just some representative images as to what that burden looks like visually. Next slide, please. So once we get the score, we can then put it into further calculators that help calculate a percentile rank, because this is a very important point to make, that the numerical score itself is not the full story. We have to compare where the patient ranks in relation to their age and gender match peers. So if you look at this example here for a 57-year-old male with a score of 30, this places him somewhere in the middle. His percentile rank is 58. Now, one important risk threshold, which takes this into consideration, is the patient's percentile rank. If it is greater than the 75th percentile, then regardless of the actual numerical number, this would indicate prematurity and should be considered high risk. So as a quick example, if you had a 45-year-old patient with a calcium score of 30, the number of 30 might not seem numerically very high, but a score of 30 in a 45-year-old male would be premature with a high percentile rank. Next slide, please. So coming on to how we assess calcium on this lung cancer screening CTs. Now, there are certain technical differences, the first of which is the lung cancer screening scans will not be ECG gated, so there might be issues of cardiac motion. If the patient is very tachycardic, the tube voltage is variable depending on patient size. This might affect the attenuation of the coronary calcium. The scan mode is different. The reconstruction is slightly different. So there are technical differences and they're not directly equivalent. But that being said, even if you account for these technical differences, there is generally good agreement between a Agatston calcium score and what you get as a qualitative assessment of calcium burden from these non-contrast chest CTs. Next slide, please. In terms of how chest CTs will have their calcium scores reported, as Asha alluded to, it really comes down to who is reporting it, whether the reporter is a radiologist with cardiac background or whether this is a radiologist without cardiac training. And in the literature, there's really two approaches. The first of which is, you do get a numerical score where each artery is graded 0 to 3. The score is then tallied up to give a maximum score of 12 if the left main and all 3 arteries have severe calcification. But what I suspect will be more likely reported in the local context is that the reports would probably just include a visual estimate. So this would be an eyeball estimate of no calcium, mild, moderate, and severe. And again, this has been looked at in the literature as well. The agreement with the Agatston score is lower, but it's generally still pretty good with a kappa of 0.7 to 0.8. Next slide, please. So, visual estimate, not as good as a numerical Agatston score, because obviously we can't give you a percentile rank, but there is still good prognostic data. And the prognostic data from just a visual score does actually match the risk thresholds that a MESA calculated, percentile rank would actually give you. Next slide, please. So again, with the reports, you would probably get just a visual estimate. And if we consider the risk thresholds, which I showed earlier on, 0, 1 to 99, 100 to 399, more than 400, more than 1,000, then we could perhaps, match what the visual estimate is to what we would expect the Agatston score to be. So obviously, if someone has no visual coronary calcium on the chest CT, that would probably suggest a score of 0. If the grade is reported as mild, that would probably correspond to a score of less than 100, moderate 100 to 399, and severe more than 400. Next slide, please. Now, in terms of practicalities, what do we do with this information? So this would obviously come down to the question, should we prescribe aspirin and statin? Now, if someone has a score of 300, this would probably be the equivalent of a moderate grade. And we know that once someone's calcium score is 300 or higher, their risk of an infarct is the same as someone who has had an infarct, someone who has established coronary disease. So clearly, in patients who have had prior infarcts, prior PCI, the question of a statin is pretty clear. And in someone with moderate grade coronary calcification, if there are no contraindications in terms of increased bleeding risk, there would be benefit of use of a statin. Next slide, please. Now, if someone has severe or extensive grade visual coronary calcification, this is a very unique high risk category. Patients in this group usually have additional extracardiac calcification as well. So, there might be comment on aortic valve calcification, which might actually imply aortic stenosis. This is outside of the scope of my talk, but certainly if valvular calcification is described, an echocardiogram should be considered. And obviously, if the grade of calcification is reported as severe in the coronary arteries, risk factor modification should be very aggressive. Next slide, please. Coming back to aspirin, this issue regarding use of coronary calcium scoring to guide primary prevention aspirin has been looked at in quite a few publications, and this is one of the key publications looking at that issue from the MESA cohort. If I draw your attention to panel A, when all patients in the MESA cohort were looked at, the number needed to treat to prevent one cardiac event at 5 years is represented by the blue bar in panel A, and you need 476 patients on primary prevention aspirin to reduce the risk of one cardiac event at 5 years. But the number needed to harm in terms of bleeding is low at 355. So if you don't use coronary calcification to stratify who might benefit or harm, then there's really net harm in blindly prescribing primary prevention aspirin. If you look at the green bars in panel A, when coronary calcium is used, once your coronary calcium score is 100 or higher, then there is net benefit with a very low NNT of 140 to derive benefit, which is significantly lower than the NNH of 355. And if we look at the adjacent panel on the right, so this panel here shows patients who are assessed with traditional risk markers, so clinical history, blood pressure, but not considering calcium scoring. If you look at the blue box, so these are patients who are deemed as having high cardiac risk, but not considering the calcium score. You have a pretty high NNT of 251 with a number needed to harm of 256. So the magnitude of benefit of primary prevention aspirin, if you were only using clinical risk markers without imaging, the magnitude of benefit is very, very modest. And in a similar manner, the moment you start adding calcium scoring, if your calcium score is more than 100, then there is benefit which outweighs the risk from primary prevention aspirin. Next slide, please. Similar manner with statins. If you look at the bottom two panels, once your calcium score is greater than 100 and obviously greater than 400, there is benefit in primary prevention aspirin. If you look at the x-axis, you can see the curves start to diverge pretty early at around the 2-year mark. So certainly in patients who are reluctant to commence statin therapy, knowing that they have coronary calcium is a very useful tool to encourage uptake of primary prevention statin. Next slide, please. So I'm coming to the end of my talk now. A question which gets asked very frequently is, when should I consider a stress test? The first thing to point out is that even if a Agatston calcium score was available, there really isn't a score threshold which mandates that you have to do a stress test. But one big pitfall which I would like to point out is that whilst the lung cancer screening guidelines require patients to be asymptomatic, in my experience, the vast majority of patients are very sedentary, and this is borne out in health statistics. And patients might consider a gentle walk around the block to be exercise, but the truth is that is too low a workload to provoke symptoms. So it might be reasonable considering stress testing if the patient has a significant calcium burden. And if you look at the panel on the right, so if patients are asymptomatic and if their calcium score is more than 400, you would actually demonstrate an inducible ischemic defect in almost a third of patients. So this threshold is just worth considering. If your patient has a high visual estimate, which typically corresponds to a calcium score of more than 400, a third would actually have inducible ischemia. Next slide, please. So just in conclusion now, coronary calcium, very common. The factors which make one eligible for lung cancer screening are the same factors which will increase the pre-test probability for calcium for coronary calcification. There's no, the overall approach is no different to how you would manage someone who is of high vascular risk. And, if you consider that to be your starting point, then obviously specialist involvement is not mandatory for all cases. I would urge everyone to pay attention to the visual grade. So if the coronary calcium is graded as moderate, then as you've heard, that would really correspond to a calcium score of roughly 100 to 399. And in this group, there would be benefit for primary prevention aspirin and statin. Obviously, if it's described as severe or extensive, then this would correspond to a calcium score of 400 or higher, and it might actually be reasonable to consider functional testing. And if functional testing comes back positive, there's a large amount of inducible ischemia, then the subsequent management pathways are no different to what you'll be doing now in your current clinical practice. And that concludes my talk. Thank you.
Thank you. So Renee, are you sharing your slides, or do you want Olivia to?
No, I'll share them.
And just a reminder to people, if you have come in on iPhone something and haven't got your name that you registered in, please rename yourself so we can mark you as attending and give you CPD points.
Let me just share my...
So we're seeing your desktop, I think, at the moment, Renee. You're sharing your desktop.
I'm going to assume everyone can see them. Can you give me a...
No, we can't see them at the moment, Renee. So stop sharing and try sharing again. Thank you. That's looking much better this time. Thank you.
Okay, great. Thank you. And thanks for a great talk, Kai, on coronary artery calcification. I think that that's where we're likely to see the most kind of benefit from incidental findings, to be honest, is in managing the incidental coronary artery calcification. And I'm not quite sure whether we can say the same for emphysema or not, but it's clearly going to be a very common finding as well, and something that we need to manage. So I'll just go over a bit some of the resources that I will be. I don't think I've. Sorry, I don't think I've moved my slide.
Okay, so you've stopped sharing and you're going to share again.
What am I doing? Sorry, this is really embarrassing, isn't it?
That's looking good. And usually in the left-hand corner, there's an arrow that
you can also just use your arrow or just click your mouse over the screen, Renee, to advance.
That's advancing now?
Yes.
Yep, great. These are just some of the resources I've used for the talk. So the National Asthma Campaign, National Asthma Council Spirometry Handbook, the COPDX guidelines, the Gold Pocket guidelines, and the European guidelines on incidental findings in low-dose CT screening for lung cancer. So as Ash has already pointed out, the National Lung Cancer Screening Program Additional Findings Guidelines have been released, and this is what is stated for emphysema at present. So unlike, for instance, when you saw liver cysts, there was a guide that said, you know, if it was less than a centimetre, there was no need for the radiologist to report. They've not really put in anything around, say, you don't need to report trivial emphysema, but what they've suggested is reporting mild, moderate or severe emphysema with a link to some guidelines. And so this is the data that Ash has already presented that we saw in our international lung screening study in the Australian cohort, that we had 57% of participants with some type of emphysema. But I'd just like to highlight that in the majority of those, so 78%, the emphysema was considered trivial or mild, most commonly mild. So is there an advantage to picking up on emphysema and treating it? And I think the three key take-home messages for this talk are that emphysema is not the same thing necessarily as COPD, that for COPD we need spirometry for diagnosis, and that for most of our treatment is linked to obviously the diagnosis of COPD rather than the diagnosis of emphysema. In 2022, the US Preventive Services Task Force released their overview of whether we should screen for COPD in asymptomatic adults who don't recognise or report respiratory symptoms. And they concluded that there was no net benefit from doing this, that there's no evidence that screening for COPD in people who are asymptomatic will improve health-related outcomes or morbidity or mortality. And for patients on the moderate to severe end of COPD, at most, the treatments that we have at the moment we think can reduce exacerbations, but not necessarily other outcomes. And they also found, a little disappointingly, that there was limited evidence showing that that doesn't support screening as a means towards improving smoking cessation. There was subsequently some evidence published to that review in the New England Journal, which was a study where I think it was conducted in Canada, where people were recruited at a population level through, I think, telephone, and people who had symptoms, respiratory symptoms, were offered screening for detection or case finding, if you like, for the detection of COPD. And those who had a diagnosis of COPD were referred to a pulmonologist for intervention. And that study showed that you could reduce healthcare, respiratory-related healthcare utilisation, but no other impact on other outcomes. So a lot of guidelines, including the COPDX guidelines, do support sort of case finding. So you can see there's an extract from one of the COPDX handbooks which suggests that people who are current or former smokers should be offered spirometry. And that suggestion there is really regardless of symptoms. So as already stated, a diagnosis of emphysema does not necessarily equate to COPD, and it shouldn't be used to diagnose COPD. Although radiologically detected emphysema can predict hospital admissions and mortality, that the presence of emphysema alone won't necessarily direct treatment. So emphysema can also be used to predict lung cancer risk and maybe to stratify our screening nodule management protocols. But it's unclear if we identify it early how this really influences outcomes. And this was the sort of conclusion of the European statement on the management of incidental findings. Their recommendation was that that they only report moderate to severe emphysema, and as you can see, that differs from the current Australian guideline for additional findings in the National Lung Cancer Screening Program. So I'll just talk for a little bit about the relationship between COPD and emphysema. So chronic obstructive pulmonary disease is a heterogeneous chronic lung condition with symptoms of cough, breathlessness and sputum production, and it's due to both abnormalities of the airways, so bronchitis and bronchiolitis, and or the alveoli, which is the emphysema component, which persist and are often progressive and lead to airflow obstruction, with airflow obstruction being the key feature of COPD. So spirometry is mandatory to establish the diagnosis of COPD, and people shouldn't have a label of COPD without it being confirmed with post-bronchodilator spirometry. So just this is a slide which shows the difference between sort of mild emphysema and severe emphysema. So you can see in the milder form there's sort of these centrally lobular areas of lucency, but a lot of the background lung is normal. Here in the more severe form you can see a lot of larger sort of lucent areas, more diffuse. And so emphysema being a sort of the permanent enlargement of air spaces distal to the terminal bronchioles. This also differs from chronic bronchitis, which is a clinical definition based on the chronic cough and sputum production for at least 3 months of any 2 or more consecutive years. And here we have a sort of Venn diagram, which sort of is an attempt to show the relationship between emphysema, chronic bronchitis, COPD, and airflow obstruction and asthma. But you can see the shaded area is what you might call chronic obstructive pulmonary disease, and that there's a group of patients who have emphysema isolated without necessarily having airflow obstruction or without having chronic bronchitis. There are some patients that may have an overlap between emphysema and chronic bronchitis, but not necessarily airflow obstruction, suggesting COPD. And some patients in the middle here might have a mixture of sort of asthma, COPD, emphysema, and chronic bronchitis. So there's a wide overlap between these different conditions. But most of our treatment are based on the presence of spirometry confirmed COPD. So this is just a slide to talk about spirometry in a little bit more detail. The definition being of chronic airflow obstruction of being an FEV1 to FVC ratio of less than 0.7 or 70% post-bronchodilator. And here you can see what we see with a normal flow volume loop, where during expiration there is a sort of straight sort of slope here to the end of exhalation. During exhalation in a patient who has COPD, the flow rate is significantly reduced, and so it takes a lot longer to exhale the volume of air in 1 second, the FEV1, and the FEV1 to the forced vital capacity ratio is reduced. So you might have patients who have airflow obstruction at baseline on spirometry, but when you give the bronchodilator, that's resolved, and therefore they don't necessarily have, do not fit the definition of having COPD. If someone has a very significant bronchodilator response, you might entertain that they might have an asthma diagnosis. So if their FEV1 improved by more than 15% or 400 mils, but you would sort of correlate that with their history and symptoms. And I wasn't going to go over in detail, I'm just looking at the time, sorry, the management of stable COPD. I'd refer you to the COPDX guidelines, but the management is very much based on assessment of symptoms and the history of exacerbations, with people with mild symptoms often only needing short-acting bronchodilator therapy and increasing pharmacological management in those with more severe symptoms. And in all patients, though, non-pharmacological measures such as tobacco, smoking cessation, appropriate vaccination according to immunisation guidelines are important. So one of the key measures in terms of symptoms is the level of dyspnea, and the Modified Medical Research Council dyspnea scale is very useful in this context. Some guidelines also recommend the use of the CAT, which is a COPD assessment test, but I think a simple assessment of breathlessness is helpful. And you can see that people with sort of grade 0 or grade 1 dyspnea, grade 1 being breathlessness when hurrying on the level or walking up a slight hill, those symptoms are quite mild, and we manage usually just with short-acting bronchodilators as needed. But when people get to a point of needing to slow down on the flat ground to keep up with people of the same, and aren't able to keep up with people of the same age, or need to stop on the flat ground, then that's the point at which you might add long-acting bronchodilators in either sort of single or dual combination. So I just wanted to touch on the fact that COPD currently is very poorly diagnosed on a global scale, and not just in primary care, but also in my experience in the tertiary care setting. And so I think that this creates a sort of, there are system issues that are very difficult to overcome, basically, and I'd be mindful of that as we sort of go into this National Lung Cancer Screening Program. So often people are misdiagnosed, are labelled as having COPD when they don't have COPD, and the reverse is true, that people who do have COPD are not being detected. And it's interesting that this is a small study from one of the pilot studies in the UK of screening, which was, they called a targeted health lung check. But you can see that of those who had low-dose screening CT for lung cancer, 73% in this cohort had emphysema. And just if you look at this moderate group, you can see that of the proportion that went on to have spirometry to confirm the presence of COPD, whether it was confirmed on spirometry or not really didn't necessarily impact in the way you would like it to, as to whether a new primary care diagnosis of appropriately appeared in the medical record. And so the concern is that without appropriate spirometry and follow-up, people may be given treatments that are not necessarily indicated, and this is something we just need to be mindful of. So I think the key conclusions are that emphysema is very common, that it may or may not be associated with COPD, and vice versa, that the presence of symptoms such as breathlessness and cough are the most important things that should guide spirometry, and these should occur, the spirometry should be requested regardless of the results of CT scans. When patients are being assessed for lung cancer screening, if they have symptoms of cough and breathlessness, that's the point at which I'd organise spirometry regardless of the scan results if they haven't had it in the past. And that our guidelines are primarily directed by symptoms and exacerbation histories. That's it from me.
Thank you. So we welcome Dr. Alistair Miller now on interstitial lung abnormalities. Al, are you able to share your screen, or do you want Olivia?
No, but
okay.
Thank you, Sue. And look, I'm speaking third, I think, because interstitial lung abnormalities are much less common than the other two things we've talked about, and perhaps less important. So there are a number of other pulmonary findings that may be found incidentally, ILAs, which I'll talk about, but also bronchiectasis and other diffuse lung diseases, either cystic lung disease or nodular lung disease. But they are less common, and certainly I'm only going to talk about interstitial lung abnormalities today. I think they're worth talking about because they're a relatively new phenomenon.
can't hear what?
They were really only formally described by the Fleischner Society about 5 years ago. And they, at that time, described them really as a radiological description. They described CT findings that were potentially compatible with an interstitial lung disease, but were found incidentally, so found on scans that were performed with no pre-existing suspicion for an interstitial lung disease. There is a more recent paper from the ATS where they've called into question whether these need to be incidental or not. But I guess in the context of what we're talking about tonight, lung cancer screening CTs, then it's a bit moot. We know that they're quite common. Up to 10% of smokers may have an interstitial lung abnormality found on a scan. And as Asha described earlier, about 6% of Australian people screened in the International Lung Screening Trial were found to have an actionable ILA. And importantly, it doesn't imply symptoms or indeed the absence of symptoms. And if there is symptoms, it may well be a mild ILD or a subclinical ILD, I guess, in the absence of symptoms. So these are non-dependent abnormalities that affect more than 5% of one of 6 lung zones, broadly broken up into upper, middle and lower, as you can see, divided up on this chest X-ray. There are defined cutoffs. The aortic arch and the pulmonary veins form those cutoffs. But as you can imagine, trying to establish a 5% amount is quite challenging, and even for our specialist thoracic radiologists who look at these scans all the time, they find it really difficult to confidently say whether you've reached 5% or not. They're further subcategorized as to their position, whether they're subpleural or non-subpleural, and whether or not there's evidence of fibrosis. They can be distinguished from an interstitial lung disease really by the extent of the findings. So rather than 5% of one of these lung zones, an ILD really needs to have 5% of the entire lung. There may be abnormal lung function that's attributable to this. Of course, as we've heard, these people are very likely to have COPD. And so we're really looking for a restrictive defect rather than a obstructive defect that we see with COPD. And again, someone with ILD is more likely to have symptoms, although that's not a good distinguishing feature. So what are the findings we're talking about? And on the left here, you can see some ground glass opacities. In the middle, some subpleural reticulation. And on the right, more findings of fibrosis with some architectural distortion and traction bronchiectasis. Some findings that may be reported but are not ILAs. We have any changes that are dependent. So on the right here, panel C shows some dependent atelectasis. On the left rather, in panel A, it's very common to have some fibrotic appearing change adjacent to the spine, with when you have areas adjacent to these bony ridges, then it's very likely this is UIP, but it's non-progressive and doesn't represent an ILA or indeed an ILD. And it's very common, again, because many of these people are active smokers. It's common to see centrilobular nodularity, as we can see circled in panel B, which is more suggestive of a smoking-related diffuse disease rather than ILA. So we care about them because some of them, at least, have quite a significant prognostic impact. There is a range of prognosis seen with the ILAs, stretching from non-subpleural ground glass changes, which really have no impact, through to a subpleural UIP pattern type fibrosis, where you see marked architectural distortion and honeycombing, which does have a significant impact. We know that ILAs in the lower zone rather than the upper zone are more likely to progress. And if we see signs of fibrosis, so presence of traction or honeycombing, then again, these are more likely to progress. In the Framingham cohort, which is obviously a cohort looking at cardiovascular risk, when an ILA was found, about 6% progressed over the period of observation, and there was an accelerated decline in lung function. In lung cancer screening trials, ILAs were found to progress about 20% of the time over a 2-year period, and that's an important figure, as we'll discuss in the management. And over 5 years, about 50% were shown to progress. Of those that had non-fibrotic changes, about 50% actually resolved entirely. We know that ILAs are associated with generally increased mortality, and that's in excess of that might be associated with an interstitial lung disease if it were to progress to that. It's associated with increased cancer-related mortality, increased cardiovascular mortality, and certainly holds a higher risk of complications of therapies should they have cancer. The risk factors are very similar to those that we might see in people having this screening at older age, male sex, a history of smoking, or indeed other inhalational exposures. There are some genetic predispositions, and anyone who's had any thoracic therapy, really, whether that's chemotherapy, radiotherapy, or surgery, are all more likely to have ILAs, indeed, that progress. So within the lung cancer screening program, any ILAs are reportable. And I guess that's any ILAs that reach that 5% of a lung zone amount. And it's really on the features of that as to what recommended management exists. And so it all exists within the framework of the National Lung Cancer Screening Trial, in that these people will have ongoing scans with a maximum interval rather of 2 years. And I guess that's important because, as I talked about, only 20% of these, and it's the more fibrotic ones, were found to progress at 2 years. And so generally speaking, if they don't have high risk features, we can afford to see them again at their next screening CT without significant worry about progression. So as I said, that if these ILAs are reported, then management is really delineated by the presence of high-risk features, and that is features of fibrosis. And so it's evidence of subpleural reticulation with either traction bronchiectasis, so enlargement of the airways far out into the periphery of the lungs, or the presence of honeycombing. If it's present, then the recommendation is for a clinical review to get an HRCT, including with prone views, and that's important to show that it doesn't just go away with in what was dependent lung, and then refer for a respiratory review. The clinical review is really looking for the presence of comorbidities, things like a connective tissue disease, asking about symptoms that might be attributable, asking about occupational exposures, particularly, I guess, at the moment, things like silica, but any other dusts or significant inhalational exposures, a presence of family history, and symptoms and crackles on examination. Whilst it isn't part of the Australian screening program recommendations, spirometry may be useful for some people, particularly in those who have got crackles and who have attributable symptoms. and it's only recommended in the European guidelines. If there isn't any high-risk features, then the recommendation is still for a clinical review and ongoing scans as per the program. However, if there are features on clinical review that are concerning for an interstitial lung disease, then referral is entirely reasonable. So to summarise, up to 10% of scans will have an interstitial lung abnormality reported. Some represent an interstitial lung disease, often asymptomatic or early in nature. We know that those with fibrotic features are associated with progression, have some mortality significance, and are associated with malignancy. And so really the first step, if these are reported, is to assess clinically for signs and symptoms that might suggest an interstitial lung disease, and refer for high resolution CT scanning and review with the respiratory service if appropriate. Thank you.
Okay, thank you, Al. Okay, are people seeing my slides?
Yes, we can see them. Thanks.
Great, thank you. So, I'm a GP and just really keen to bring a little bit of a general practice perspective here. So just wanting to share some things that a reminder about a lot of things that we already do in general practice, and I'll just skip through this because in the interest of time. So as GPs, we are really important in this, the lung cancer screening, to identify those eligible patients for screening and navigating that informed consent and educating patients about what the expectations are, that there are possibly going to be some of these additional findings. Then we do also need to be involved in that follow-up if there are additional findings. Now, a lot of the skills that you use will be similar to the ones that you've already been using when you have people in screening programs for breast, cervix, and when you have those discussions about prostate screening, and if you might find incidental gallstone cysts, all those sorts of things. So this is stuff that you're already doing. And you are expert at sharing the uncertainty and sharing challenging information with patients that you already know. So for patients, this additional findings on screening might be turning into an anxious time for them. If you do call patients back, they might think, oh gosh, that means I do have cancer. So it's important as GPs that we help to reduce their distress, we build on the trust we already have, and get towards an understanding of what the next steps are. And it's really important that you choose to use calm, reassuring language, being that calm raft in the storm of their emotions if they're getting upset about what might this mean. And a lot of the findings are things that you can perhaps use it as a lever in getting people involved in health screening. So we're going to frame these things as it's part of proactive health screening. We're catching things early, and often it's not urgent because it's a cancer. It's actually something that's early in the. So there are some different frameworks that we can use. So one framework is potentially using 4 A's. So we acknowledge, assess, advise, and arrange. So, for example, you recognise and acknowledge the patient's emotional response. I understand this might be a bit of a surprise, but it's okay. It's okay to feel concerned. Assessing what they already understand, what story is in their head, what are they imagining? What are their ideas, concerns, and expectations about this? So you might ask, have you heard the term, it might be like the nodule or calcification or ground glass, what comes to mind when you hear that? So just probing, what is it that they understand? What's the story going on in their head? And then you in your great calm manner, advise them in simple language that, you know, this is quite common. A lot of the time it doesn't mean anything serious. It doesn't look suspicious, and we're going to be following the guidelines. We'll be monitoring things, and then arrange quite clearly what the next steps are. So you'll have hopefully got some ideas from the guidelines that this is a particular program that you need to follow. So we'll be arranging a follow-up and in X months to check any changes. And if things change, you know, we will refer, but for the moment, it's just keeping monitoring and following the guidelines. If you want something shorter than the 4 A's, there's 3 R's. So you could reassure, you know, things like these findings are quite common, harmless, usually. Then risk frame. Now, based on your scan, your background, your health, your risk is quite low. And we're following guidelines that will catch anything serious early. And then what is the roadmap? What is the way forward? So this is what's going to happen. We're going to repeat the scan in maybe 12 months. And then if things change, we'll refer you to a specialist. So being quite calm and considered and reassuring with your reassuring, giving them an idea about the risk and what the roadmap forward is. And avoid language like we're just going to keep an eye on it. So give people a clear roadmap. So we might not have all the answers immediately, and that's okay. So communicate with confidence and make sure that you follow the evidence and the guidelines. And important to book follow-up appointments, because patients might not think of everything at the time. Often when they're delivering challenging news, people go blank. So make sure you do follow up, book a follow-up appointment for those extra questions that they've got, any further reassurance that might be needed, and to take advantage of this surprise that this might be the lever that you need for health promotion to get people to listen to some of the, lifestyle changes that might help them. So remember the RACGP Red Book, which only has a red apple on it now, but it used to be all red. So that Red Book is there. It's online on the RACGP website, and it's got all the guidelines for preventative activities. So all the different things that you can do looking at prevention in people. Think about doing a health assessment. This might be a good reason to do a health assessment depending on their age and how frequently that's been done in the past. So there might be some things that patients say, like, do I have cancer? And you might say, look, this is something the screening's picked up and we need to monitor it. And they're always going to be saying things like, well, what do I do now? And this is where you can reassure them again with I've got a clear plan. We'll guide you through each step, and there's support if you're worried. So, there's mental health support. There's all sorts of other things as well if people need it. And again, it's your health promotion opportunity. So just some examples. If people have coronary artery calcification, you might want to say, look, your scan showed some early calcium in the heart arteries, and this gives us a chance to look at your heart health before symptoms start. And then you can follow up with further cardiovascular risk assessment, lifestyle, and as appropriate, any pharmacotherapy. And if it picks up emphysema, as we heard, it might not correlate, it might be subclinical. Nothing's going on yet. It's just a radiological finding. So you might say, look, this tells us your lungs have got some signs of long-term air space damage, might be related to your smoking. And if you're not feeling symptoms now, we're just going to monitor your lung function. And so this is where, as Renee was talking about, do your spirometry, hopefully get them to think about smoking cessation, and get them in for annual, regular checkups where you can check in on all of that. And just reminding you, use simple, culturally sensitive language, be aware of medical jargon, avoid words like lesions and mass without explanation, because again, people often think cancer. Sometimes people don't understand benign. So really use simple language, check what the patient understands, check in what their ideas, concerns and expectations are. And with Aboriginal and Torres Strait Islander people, there are often challenging health experiences that they've had. So really, try to make it a culturally safe space and, you know, offer an interpreter if that's required. And many of our patients may not be as health literate as you expect. So really important to use diagrams, have some handouts ready, and, you know, give written summaries. Make sure that you give some patients information to take away, information that they can share with their loved ones if they can't remember everything that you've spoken about. So in summary, just wanting to make sure that you are aware in your informed consent that additional findings are just a part of lung cancer screening and they're likely to come up. And your communication can reduce that fear and help patients really understand and clarify what those next steps are. Think about using the frameworks like the 4 A's or the 3 R's to help you guide that discussion when you've got that report to share with the patient. Make sure you follow appropriate guidelines, and remember Health Pathways, which we'll be talking about a bit later on, is there for you to look at whenever you need to. Make sure you book up those follow-up appointments and take advantage of this as a time for health promotion and answering any further questions the patients have. And these are your patients, you know them. So remember, think about what is their health literacy, what's the cultural considerations, do we need interpreters, do we need health promotion material, do we need handouts, diagrams, all those sorts of things. So thank you. And over to you, Asha.
Wonderful, thanks, Sue. We might just bring up, we just have a few more post-presentation poll questions before we move on to the next section. So if you could just take a few minutes to go through those and select your responses. So there's only 4 questions. The first one is how confident you feel managing additional findings detected on lung cancer screening. If you scroll down, there's another question, I feel confident about assessing incidental emphysema. And again, you can strongly agree to disagree in terms of your responses. The third question is, I feel confident assessing incidental interstitial lung abnormalities. And finally, I'm confident in assessing incidental coronary artery calcification. So we might just give that another few minutes. And while we do that, I will load. All right, Olivia, I think we can probably end the poll there. Excellent. All right, and I'll move on to the RMH referral pathways, which if you've been to any of our previous talks, you might have heard me mention before, and they are now active. So I'm excited to share some more information about that. But before I do, I just wanted to remind you about some of the resources that are available. So our talks, so we've done 2 earlier talks. One is looking at the National Lung Cancer Screening Program overall. And then we've also done another session looking at lung nodules, not just screen detected, but also incidental. And those are available online through the Northwestern Melbourne PHN website if you want to have a look and you haven't seen those ones yet. There are also some really great resources from the National Lung Cancer Screening Program itself. Specifically, there are some resources for healthcare providers, but there's also some really good handouts that you can give for patients as well, particularly if you're having discussions about nodules or additional findings and you want some written information. But as I was mentioning, our lung nodule and cancer screening referral pathway at the Royal Melbourne is now active. So this is a pilot program and research project which is being funded by the Victorian Medical Research Acceleration Fund, and the RMH Foundation, which will be available at least until early next year. And it composes of two parts. The first part is we do actually have an advice hotline for healthcare providers, which you can either contact us via phone or you can send an email in. There is more information about the project on our website. As part of that, if you have any questions about lung cancer screening or lung nodules, even if it's about managing patients in the community, we're very happy to provide you with some advice. We are also able to provide you with written advice. We just need a few more details, and then we can give you something in writing that you can put in your patient's file as well. We also have additional outpatient clinics, including for non-screen detected lung nodules, as well as those high-risk lung cancer screening results. That includes a multidisciplinary meeting, and as well, there's actionable respiratory additional findings that are detected on lung cancer screening. So if you do have patients that do require respiratory review, then please do send in a referral. You can send it either through the email address or through the existing referral pathways at the Royal Melbourne Hospital. You're also more than welcome to give us a call or send us an email if you want to discuss the referral before. We do just say, if we don't get back to you right away, then usually our response time should be within 2 business days. As this is part of a research project funding, there is a patient information sheet that we do ask that you just give patients, if you are contacting our services. It's available via the website and also via health pathways. We will also confirm with patients as well that they've got that as a secondary measure. And that's it for our pathways. I'll hand over to Hashini.
Hey, I'm just gonna try to share. Is that the right? Sorry, is that the right page?
Yes, it is. Thanks.
Perfect. Great. So hi everyone, I'm Hashini, so I'm a GP, but I also work as a clinical editor for Health Pathways Melbourne. So today I'll be talking about what Health Pathways actually is, how it can be a great resource for you, and I'll also show you how the website can help you navigate that new lung cancer screening program and how to easily access referral pathways for your patients. So this is what the Health Pathways website is, just the one on the top. It's a single website that gives clinicians access to clinical pathways, referral pathways, and other resources. Health Pathways Melbourne is run in collaboration by the Eastern Primary Health Network and the Northwestern Primary Health Network. The pathways are written by GP clinical editors such as myself, with support from local public hospital-based specialists in the relevant topic or other subject matter experts as appropriate. And then they're also reviewed by other local GPs. The clinical pathways are evidence-based, locally relevant, and kept up to date. They're kept clear and concise and designed specifically for use during consults. With the referral pathways, these include information on referral criteria and the local services available, separated by catchment areas. So in terms of how to access the pathway website, like I said, it's right on the top. Also, there's a QR code on the screen as well that you can use. So this is what the homepage looks like. The homepage includes information such as latest news, which includes health alerts and updates, and the side panel on the left acts as a contents page. The arrows just on the bottom left show where the lung cancer section is. Here it's in the respiratory section, but it's also in the oncology section. You can also just use the search button at the top of the page to find what you're looking for if needed. And on the bottom right, you'll find the feedback button. That's if you ever want to give feedback for any reason, such as if you think extra information or resources could be added, or if you have any other suggestions or comments on a page. This is just a quick overview of some of the respiratory pages that we already have on our website, just to give an idea of what kind of pages exist. Each of the clinical pathways on the left typically has information from a brief background on the topic, a section on assessing a patient, so history, examination, investigations, and a management section, so indicators for referrals, such as indicators for referrals, as well as non-pharmacological and pharmacological management. There's also the referral section with advice on when, how, and where to refer. We also have an information section that lists a few useful resources to get further information for yourselves, and a similar section for patient handouts.
The referral pages on the right also includes referral criteria and services available, and these are separated by catchment areas. The services listed will all have details, including like contact details and relevant links. They'll also be separated into public and private options. So in terms of the lung cancer pathways, there's been 2 new pages created with the new lung cancer screening program. We've got the lung cancer screening page, which talks about the screening pathway itself, all the way from assessing a patient and their eligibility to managing their results. The lung cancer screening services page talks about where to send any referrals for a patient as part of the screening program. And it includes both scan referrals or referrals to the respiratory physician. So this is what the lung cancer screening page itself looks like. So that we've got a See Also section, which provides links to other relevant pages. For example, here we've got the lung cancer screening services page, a page if you suspect the patient has lung cancer, so if they've got symptoms, the smoking and vaping cessation page. This page has a clinical editor's note at the moment, so we put these on pages where there's been a recent update or new information. So for example, here we talk about the new Royal Melbourne Hospital referral pathway that Asha was just talking about, and its advice hotline, as well as the Lung Foundation helpline. So just a quick run through of the page. So we've got the background section, usually just brief important points about the topic, and then the assessment section with steps to work through, typically in order. So there's drop downs within the assessment steps that you can open. So for example, the eligibility drop down, which I've just opened, reveals the eligibility criteria, including a PACIA calculator. Also number 9 here has links to the program specific radiology form to use and a link to the National Cancer Screening Register to enroll the patient. The management also has numbered management steps to work through, such as what to do on the CT scan, what to do based on the CT scan results when you get them back. So for example, the low risk scan would be a follow-up in 12 months, and also what to do with follow-up scan results as well. So it's got a link to the nodule management protocol flowchart, which illustrates what to do in the setting of a growing or a non-growing nodule. In the management section, there's also the additional actionable findings section with a link to the guidelines that Asha mentioned right at the start of the night and what results we might expect. Lastly, we've got the referral section and the information section with the links for other resources for our health professionals or patient-appropriate websites or handouts. This is the lung cancer screening services page. It has the same clinical editor's note as the other page. And it also has information about the radiology services involved in the program and the program-specific radiology form again, and what information to include in a referral. It also lists lung nodule clinics where you can refer your patients to. So here's a quick overview of the clinics that are currently accepting lung cancer screening patients. There's more information in each of the drop-down sections about how to refer to each service specifically. Cool. And so if you work within the eastern or the northwestern catchment areas, you can register for access to Health Pathways Melbourne. So you can just use the QR code or just go to that website, which is on the bottom left. Great.
Thank you very much, Ashini.
Thank you.
So, thank you. And remember, GPs, Health Pathways is your friend. It is one place where you can get all this information. You don't have to carry it in your head. It's really awesome. And if there's anything you find that's wrong, press the feedback button and it can get back to the people if you find that something is wrong. So we now have question and answers. So I haven't seen anything in the chat, but if people want to put things in the chat, if you've got any questions or what is the best thing to do, if anybody would like to put things in the chat or raise your hand. I'm not seeing any questions. So are all our participants happy? You're all going to look at Health Pathways for your answers? And just a reminder, if you are just in as something like iPhone, you need to rename yourself. Otherwise, we won't be able to give you CPD points for tonight. Amy, if you'd like to unmute. Amy, did you want to ask a question? No, well, we're coming right 3 minutes to time. Is there any closing comments that any of our speakers would like to make, or any reminders? This is an opportunity. Well, we've got any last minute things you thought of or take home messages that you'd like to share in our last 3 minutes.
Kai Leon, cardiologist here. I might just want to make a quick comment about coronary calcification, because I see this quite a lot in my practice. So as I mentioned earlier, with the lung cancer screening CTs, we don't get a numerical score. So you always need to interpret the described burden in the context of the patient's age in particular. And it's also very important to really try to elicit any symptoms, because just as an example, in a patient with a calcium score of 0 and chest discomfort, 1% will actually have obstructive disease because of non-calcified plaque. So just because someone might have their coronary calcium burden described as mild or low burden on the lung cancer CT, and if they're describing chest pain symptoms, the description of a mild burden does not exclude obstructive disease. Further testing in the form of a contrast cardiac CT or a stress test might be needed. So that's the main thing to bear in mind. The test does not exclude obstructive disease.
And can I clarify with you, Kai, as well? Because often when we see patients with incidental coronary artery calcification on low-dose CT, sometimes they will then be referred for a coronary artery calcification score. But often I would say that wouldn't necessarily be needed. We're looking at more of that risk and functional assessment. So in terms of practical next steps, what would you suggest in terms of further assessment beyond the risk factor for modification when you talk about functional imaging or testing?
Yep, that's a very good point to clarify. So, the first thing is calcium scoring is obviously not rebated, so there's an out-of-pocket cost, and you can roughly get the same information from the lung cancer screening CT. So it's really a duplication of testing. It's really not necessary. And if you just recall the slide that I showed earlier, the visual grade does correspond quite well to an Agatston grading. So, statins and aspirin should be considered if a moderate grade is described. Functional testing would mean things like stress testing, so stress echo, nuclear stress testing. And, if the patient, is able to describe a very, very high or high workload with their regular exercise, then again, you have to remember there's no actual threshold which mandates that you must do stress testing. So again, it just comes down to the overall patient. Do they have any other cardiovascular risk factors? Do you think their level of physical activity and their asymptomatic state is truly prognostically helpful? But, if the patient has lots of other risk factors like renal impairment, diabetes, and you're not really certain they're truly asymptomatic, and these are the patients that you should think about doing stress testing on.
Thank you, Kai. Now in the chat, we just have one question, and that's about for lung cancer screening. Does the patient have to present to the clinic? So with the lung cancer screening, it's up to the clinic and the GP to do the case finding, and it is quite specific what you need to do to case find, and it is important that you check who's eligible. So go to Health Pathways, and that will step you through what you need to do to find out if someone is eligible. And so just need to check that they're eligible and do that. Now, if you can please, this is the end. We're right on 8 o'clock. So thank you for joining us. Thank you for staying with us. And if you can do your scan for the QR code for the feedback, or it will be sent to you in an email if you don't get a chance to do it tonight. But we will usually also send you out the slides and resources. So please look out for that. And the important thing is, if you do want your CPD points, please make sure you have your name renamed so it actually records who you are registered as. Thank you. So just reading the last screen, if you can do your feedback and look forward to seeing you in the future at another event.
Sorry, Sue, we've just had 2 questions come through via the chat.
So, does the GP have to register the patient on prior to the referral? Yes, they need to be registered on the cancer register prior to referral, and that's Ash has answered that. And can specialists refer? As long as they do all the right things, but I think you probably need to include the GP somewhere.
Certain specialists can, not every specialist. So for instance, respiratory physicians are one of the ones, I think medical oncologists are the other ones, but generally we wouldn't routinely do that in the public setting, particularly because then there's the review of the results, and most results will be related to additional findings, which is obviously where general practice would be very key, and the reports get sent to who registered the patient. So it wouldn't necessarily go to the GP if we were the ones referring.
Yeah, so it is, ideally GPs are the centre of care for, holistic care for a patient. Results are meant to go up to My Health Record, but you don't want to have to rely on that. Ideally, the person who's going to do the ongoing care and giving the results will be the person ordering it, and that's part of, being whole person, patient-centered care that we do in general practice. Thank you, everybody. Thank you for a really informative session, and we look forward to seeing you in the future at another one. Thank you. Okay.
Thank you.
Thank you for